Hello, Dr. David McFadden here from the Dental Implant Center in Dallas, Texas. I think today's topic is going to be really interesting for all of you out there. To our subscribers, welcome back, and to our new viewers, glad you're joining us. So this is our office in Dallas. So today's topic, I wanted to show you 10 of our 25 most recent cases. And they say when we're presenting to the boards, they're not cases, they're actually patient treatments. But anyway, the topic is implant bridges, or FP1. And I'm going to start using those interchangeably starting this presentation. So let's go through some definitions first so that you understand what it is that I'm talking about. So Dr. Carl Misch, probably 20 years ago now, in one of his famous implant textbooks, he described a classification system for full arch implant treatment. And for the fixed treatment, like all of you are here to learn about, he described them as FP1, FP2, and FP3. And just to remind you too, all my videos tend to be on the long side, so you can always pause the video and read the screen, or you can go backwards and look at something that I may not have pointed out. And as always, we'll leave some links to other associated videos in the description box, and you can leave comments as well, and we welcome those. I try to answer the more technical ones myself, so if you have questions, get them out there for us and we'll try to get back to you as soon as we can. But anyway, back to the classification system. This is really important for the rest of today's discussion, and that is the FP1 and the FP2 are the restorations that we do that look the most like natural teeth. FP3 is the ones with a lot of the pink porcelain or the pink zirconia that I complain about all the time, that our all-on-4 doctors do. So if you come to our practice, we are going to try to give you an FP1 or an FP2 all the time. That means it's going to be no bone reduction in the upper arch. Sometimes we have to remove a little bit of bone in the lower arch. But FP1 and FP2 are the most lifelike full arch restorations, and that's what we do, several of these a week. And I'll get into some of the reasons I'm doing this video in a few more slides. But basically FP1 is easier than that. Let's go through it. The implant bridges that I talk about all the time are FP1 and FP2. So I wanted to show you an FP1 basically just replaces the tooth. So here's a bridge, and here's what it looks like intraorally. So FP1 or implant bridge, we're just replacing the teeth. And the way we can do this so consistently and so successfully is that we don't remove bone. And I know that a lot of you don't know that about all-on-4. But if you've watched any of my other videos, I know that you know. But for the new viewers out there, all-on-4 treatment, which is available everywhere all the time, requires massive bone removal. Anywhere from 12 to 15 and sometimes 18 millimeters of bone. So what we try to do here is no bone removal treatment. And that will yield results like this consistently. Like I said, we do several a week. Implant bridges can also be FP2. And FP2s look more like this, where you come into us and you're already missing some of your bone. Whether it be periodontal disease or some missing teeth, you're already missing some of that bone, but we're never going to take away bone in the upper arch. So all that means is your teeth are going to be a little bit longer. If this is normal, if this is the normal length tooth to right here, that would be an FP1. An FP2 simply is a longer tooth. That's by the definition of Dr. Misch. There is a caveat to that. There is a slightly in-between classification. I'd call this maybe FP2A, where the patient came in with a little bit of bone loss, and we had to put some pink porcelain in there to keep her teeth from being really long. So it can happen with minor bone loss, or it can also happen if your papilla, the little pink triangles between your teeth, are gone. You may end up with an FP2. But it is still a phenomenally good restoration. It's just like an FP1. The only difference is the pink. We still contour everything convex, not concave like the all-on-4. And whenever it's convex, you can clean it very easily at home, and we never have to remove these restorations. So don't think that pink means it's some sort of a compromise, because it's really not. Then we move on to all-on-4, which is FP3. This is all that's offered in the all-on-4 practices. So if they try to tell you that it's an implant bridge, I'll bet you we have four other videos out there that talk about the differences. But all-on-4 equals FP3 all the time. So on any given day in the United States, there's probably, gosh, I'm going to say there's probably 10,000 people getting all-on-4. They're all getting FP3s because they remove bone before they place the implants. So this is what an FP3 or an all-on-4 looks like. Massive amounts of pink zirconia. And the result is, you know, like I say in other videos, the smile is the easy part. We can make the teeth beautiful, but this represents probably 12 millimeters of bone reduction that probably was not necessary. And part of the reason I'm giving this topic today, or discussing this topic today, is that I've heard other implant doctors who love all-on-4 and exclusively do all-on-4 talk about how implant bridges are not predictable, they're not successful, that for whatever reason they make it sound like it's a unicorn of implant treatments. And it's only a unicorn because the 10,000 people getting all-on-4 were never offered it in the first place. So we only do FP1 and FP2 here for the maxilla. No bone removal. And that's so important. I know that I've probably stressed and reiterated that several dozen times in my videos. But it's your precious bone that we're talking about. And if these treatments cost a little more, even if they cost a lot more, and they take a little bit more time, we're sparing your precious bone, which also helps your gum tissues. So what I'm trying to do today for you, for the listeners and viewers, is I'm trying to keep you from getting this and hope that you'll get this. Keep you from getting something like this, which is a toxic train wreck, instead getting something like this. And the big reason between these two restorations, both of these patients likely started out with the same amount of bone. The all-on-4 protocol requires all this bone removal that just starts a downward spiral of the bone and the soft tissues. And this, we don't remove any bone. So in case there's any doubt, this is the patient's own tissue. And clearly you can see what's happened up here, because when you remove the hard plate of bone called the cortical bone, ongoing remodeling happens for 18 months. So you're always chasing, with the prosthesis, you're trying to chase the bone loss. Down here, all the remodeling that's ever going to happen, which is just a couple millimeters, is going to happen in the first 2 months. So again, let's go back. Why is it? This is a repeat of my last video. Why is it that implant bridges or FP1s only represent less than 1% of all the implant reconstructions out there? Well, there's several reasons. The first one is they're really difficult. It takes me, we can only see one patient per day because of how much longer it takes me to do the surgery. And by the way, I never mention my partners in these videos, and a lot of you are surprised when I actually don't do all this myself. I am just one man. So I do have 2 other doctors here, and we're about to release a video where you can meet them and be introduced to them as well. So I do the surgeries, they do the teeth. And the surgery is extremely important because it sets the foundation for the teeth, the same as a foundation for a house. If you have a good solid foundation, your house should stand forever. If you have a wimpy styrofoam foundation, your house is going to fall down, right? So the main reason that there's only a few of us in the country that do this is they're really hard to get right. But it's a learning curve, right? So I don't think I have any extraordinary surgical skills, but what's different about me is that I'm willing to do something better for the patient because you all deserve that. I'm not in a rush. If it takes me 4 hours to do your surgery, it takes me 4 hours to do your surgery. You're my only patient that day. So I'm not on this tight timeline where I have to get to the next patient and the one after that to make, 3 times as much money. You'll be the only implant patient that day in our office. So we're able to go slower and make better decisions without bone removal. So they're really difficult. And the reason I want to show this again, because there's a local colleague of mine that continues to put out videos talking about that FP1s or implant bridges never turn out well because he couldn't do one on his own father. So it's no different than trying golf for the first time. And when you don't shoot par, you quit the game, you blame the clubs, and you never return. So, everything's a learning curve. From the time we're babies, we go through learning curves. This happens to be a really difficult one, where the learning, it's arduous. It takes a long time to get good at this. But today's I'm going to show you 10 of the most recent 25 cases that we've treated, and we'll have another video that comes out with the other 10 or 15 here in the coming weeks. But anyway, so many times I hear from lab technicians, other implant doctors, that FP1 is just too hard. And they're right. It is. It's really hard. I even had a technician say to me one time, the problem with FP1 is you've got to worry about those damn papilla. And I'm like, yeah. That's what we all should be worried about, is that preservation of healthy gums and bone should be our first concern in implant dentistry, not something that gets in our way. So anyway, moving on. 2 other reasons about this that make it more rare. It is more expensive. I'm going to release a video in the coming weeks about the surgical differences between FP1 and FP3, or implant bridges and all-on-4. The all-on-4 surgeons can do sometimes 4, maybe even 5 arches a day. We're lucky to do 2 because it's just so much more time, and the time does cost more. The prosthesis costs us more, so it is a more expensive treatment, but it's not so much more that you'd be forced to choose all-on-4 over implant bridges. And the treatment time. Our average treatment time from start to finish is 5 months if you have good bone and gums. If you need bone grafting or there's any complications along the way, it may take us 8. Sometimes with lots of bone grafting, it might even take 11. So those are the 3 primary reasons that implant bridges, or FP1, are incredibly rare. Far less than 1% of the reconstructive implant cases being done. And there's a new buzz in some of the online news feeds that I've seen that I want to address. I'm going to go into this in another video in the coming weeks. I'm going to be really busy over the next month. I don't know where we're going to find the time, because as you can imagine, it takes me many hours to put these together. And I'm fixing teeth during the week, and I'm here on the weekends trying to do these videos to try to educate the dental population about the differences between these treatments. So there's a claim, and it's true, that implant offices are extracting good teeth for profits. That does happen a lot. If you go into an all-on-4 center with some or all of your teeth, and some or all of those teeth are in good condition, or relatively good condition, you are not going to be told that you can save them. So the ethical way to approach this topic or dilemma is simply to say, and I'm going to make it brief because the other video will be much more comprehensive, but there are tipping points in our dental history we're born with, well, as an adult, we have 32 teeth. Minus the wisdom teeth, we have 28 teeth. So that's 14 in the upper and 14 in the lower. So there is a tipping point, and I know this personally because I've been doing it so long, that back in the day, we used to save good teeth all the time. But every patient that we tried that for, and I mean every one because I follow my patients for many, many years, within about 10 years, those teeth we saved have either broken or become decayed or have had bone loss. And in 100% of those patients, they say, why didn't we just do all of them? Well, that was 25 years ago, and we didn't know that implants could be so successful at that point, so we erred on the side of being conservative. So now fast forward 25 or 30 years, and this is the way I look at it. If a patient has any good teeth at all, tell them they've got good teeth. Just full disclosure. So, Mrs. Jones, of your 14 natural teeth in the upper, you've got 6 left that are actually pretty good. And then come up with treatment plans to accommodate those good teeth. So maybe the 6 are the 6 front teeth. Then you talk about doing implants in the back only. If they're scattered around, if you've got a couple here, one here, and a couple there, then those teeth absolutely get in our way for implant treatment. So there's where the teeth are as one determining factor. The next factor is, and this is an intimate conversation that should happen between the doctor and the patient. So most of our patients are 50 and older. Most of them are towards the end of their earning career, or they're retired and have no way of earning. So there is a financial component to this as well. And the way I approach it is, Mrs. Jones, we could save 4, 5, or 6 of your teeth, and we could work around it with implants. It's going to cost you tens of thousands of dollars to do that today. So let's fast forward 10 years, and let's say that some or all of those teeth are now ready to cross the rainbow bridge. And now what do? We're going to ask that patient to pay tens of thousands of dollars more to fix their mouth a second time. So the way I phrase it with my patients, which I think is super fair, that I would like to be informed the same way, if you can only do this once, then we should err on the side of taking your teeth out. If you can do it more than once, and some of our patients can, then I say, sure, we'll be conservative and work around your good teeth, and maybe over the next 10 or 20 years, we only have to address 1 tooth at a time with a single tooth implant, or maybe 2 or 3 teeth at a time with a 2 or 3 tooth bridge. There are certainly ways that we can take this in steps. So I'm simply going to say that yes, it's happening. People are taking out good teeth, and I think it's all about full disclosure. That's something that should be decided between your doctor and yourself. So, I mentioned treatment time also. So this is a very broad explanation of what I mean by treatment time. More than half our patients come from outside of Dallas-Fort Worth. So we talk about trips to Dallas. These treatments, if you've got really good bone, and we can get really good implant stability on the first surgery, your treatment time may be as little as 5 months. May take us three appointments, 3 trips to Dallas. But if your bone is bad, you need bone grafting, we have any complications along the way, all those things are going to increase the treatment time and the number of trips you have to come here. But we've treated so many patients from out of state now that we've tried to really streamline the process to the point where even if it takes you 24 months and you have to have 7 appointments, we piggyback some of these so that hopefully you can still only come to Dallas 5 times. And I know that's a huge commitment. And I've said in my other videos, we get requests every week. Can you refer me to somebody near me that does what you do? And we've looked and I've made phone calls, and this treatment truly is exceptionally rare. So, anyway, we do this every day, several times a week, and we get great results. So even though it's a pain, it's a burden to have to come here, many of our patients do. So these are the ranges, and after each patient treatment that I'm going to share with you, I'll tell you how long it took that patient, number of trips, number of appointments, and total treatment time in months. The other thing I want to say before we close this part of the presentation is that this variable up here, sometimes that's financial. I have a video out there that's called Don't Pay in Advance for Your Dental Implant Reconstruction. And there's many reasons why I think it's terrible to pay all your money up front. We have a pay-as-you-go system, and if you don't break your temporaries, it means you have to be super careful with what you chew, and you have to wear a nightly mouth guard. But if you don't break your temporaries, we can spread this treatment out for a couple years. In some patients, we've gone even longer than that. But the beauty there is that we can spread out the payments. So even though we might be able to do a treatment in 5 months, sometimes it takes us 24 months because of the patient's financial abilities. So I think that's really important too. And the way that plays in is it allows so many more people to get a better treatment than all on 4 because you're able to pay out over time. So anyway, I mentioned that, and we'll go into case 1, which I'm going to do as a narrated PowerPoint presentation from this slide forward so that you can get a better image quality as we make progress. So stay tuned. Okay. As promised, we're going to go through these first 10 of 25 cases with demonstration slides for each step. And I'll try to make this brief. And just remember, you can always pause and go back or fast forward if I'm going too slowly. So case 1. This gentleman presented with what we call a class 3 deep bite, meaning he's got a bulldog bite where his lower teeth are in front of his upper teeth. This is his preoperative panoramic image, and what I'm always looking for on the initial images is how much bone persists, how much bone is still present to allow us to do non-bone removal implant treatment. His first surgery, we took out all the teeth, placed these 14 implants, and he got fixed temporaries the first day. So here is that upper fixed temporary. And one of the reasons that these treatments without bone removal are so difficult is that the temporary is really what either maintains soft tissue architecture or facilitates improvement of soft tissue architecture. So all of these little areas that are convex help us shape the tissues for the final restoration while the patient heals. Here are those upper and lower temporary restorations on the day of surgery. So he came in with those terrible teeth that you saw in the first slide and left with these beautiful temporaries. It took us about 8 hours. Here's the way the tissues look 3 months later. As you can see, only minimal shrinkage has happened over the 3 months that he was healing. And I like to show these pictures too because it shows the soft tissue maintenance or soft tissue development that is accomplished with that temporary. The redness you see is usually just an allergy to the acrylic resin we use for the temporaries. Once the zirconia permanents are in there, that pinkness usually resolves completely. Here is his final restorations. As you can see, we maintained bone and soft tissue levels beautifully, and I don't want you to get too caught up in the color here. Every patient gets to pick what color they want their final restorations, and older gentlemen usually like to have age-appropriate teeth, and other people like to have bright white. It doesn't matter to us, so if you think these are a little bit too characterized, no problem. This is just what his preference was. This is the final panoramic radiograph. Here's his before and after lips retracted. Here is his before and after smiles. His treatment took us 5 months. He had 5 appointments. We piggybacked some of those so that he only had to make 3 trips to Dallas. Next up is case 2. This gentleman presented with failing upper dentition. But again, what I'm looking at here is the perceived amount of bone and soft tissues, which I believe to be quite good in his case, even though he's lost some bone around some of his front teeth. His soft tissue health and his connective tissue volume are excellent. Here's his pre-treatment panoramic image. And again, I'm looking to see where we might be able to place implants to best support that implant bridge, or FP1. He did get his teeth out and his implants placed all the same first surgery. And here's a picture of his temporary. Here's the implants, and you'll notice in some of these cases there are some retained roots. That happens when teeth are too difficult to extract without breaking the bone. We also do that on purpose to maintain the fullness of the soft tissues. If we take a tooth out and we don't place an implant in a socket, those tissues and bone will retract quite a bit, and it leaves a slight concavity where we would rather not have that. If the tooth migrates out of the bone, it's very easy to extract later. So there's several of these cases that you'll see where we did leave some roots behind, and that is on purpose. Here's his temporary bridge on the day of surgery. And here it is 3 months later after healing. Some discoloration has happened in certain areas. Again, this soft tissue architecture that we were able to maintain, this isn't even considered in all on 4. So these pictures are something I'm very proud of because this is what I would want in my own mouth, and this is the technique to get that. Final restoration in place, and you'll note again the darker colors for an older gentleman. But the soft tissues are there. Most of the papilla are still intact. Very nice case. Final panoramic radiograph. Before and after lips retracted. And for those of you who have heard so many of my other videos, if the office you're going to cannot provide you with lips retracted before and after pictures, especially the after pictures, then you need to run as fast as you can from that office because they're hiding something. And you'll note on all of my pictures, we have nothing to hide. We show lips retracted on every case. And here is the before and after smile. We didn't actually capture the before smile, but we'll remind you what his teeth looked like before. And like the first patient, the treatment time was 5 months, 5 appointments, 3 trips to Dallas. If you're local, we try not to rush the middle appointments, and for a local person it would be 5 months, 5 appointments, and 4 trips to the office. Moving on to case 3. Here's another patient with what we call terminal dentition, a person who's been putting up with failing teeth for most of their adult life, finally decided it was time to do something better. But the interesting thing about this case that I'll point out from the very beginning, you'll notice how long his teeth are. That means he's lost bone and had gum recession. So you'd think a case like this would absolutely have to have pink zirconia in it because he's already missing bone. But this is always remarkable to me that we're able to do these cases many times with this much bone loss and no upper pink zirconia. So you'll see as it progresses, this is how he came in. Here's his preoperative panoramic image. And though he doesn't have a lot of bone in the back of his mouth, he's got excellent bone from the premolars forward. And in the lower arch, excellent bone everywhere. So like so many of our other patients, all the teeth were taken out that day, the temporary bridge fabricated and delivered on the same day as surgery. And again, you'll occasionally see the screw holes through the front of the temporaries, and we use a different kind of abutment on the final restorations, and those are now invisible then. They're behind the teeth when we're finally finished. The reason I'm showing all of these temporaries is to show you all of the convex surfaces which create the shaping of the tissues. Here he is on his day of surgery. Not all of his implants were stable enough to use for the temporary, but enough were stable that we could give him nice upper and lower fixed temporaries. Here's the temporaries on the day of surgery. Here are the temporaries 3 months later. And again, I'll just keep pointing out that only the slightest tissue remodeling has happened over that 3-month period. And from this point forward, it should be stable. Pointing out again the beautiful soft tissue contours and the health around these implants because they were placed properly without bone removal, and the temporary did its job perfectly. Here's his final restoration, and like I said on his initial picture, it's remarkable that we didn't have to use any pink porcelain or pink zirconia on his final restorations because of how much bone he had missing. There's his final panoramic image, and you'll note that we lost the implant in the upper right back of the mouth. And that's one of the reasons I place many more implants than most of my colleagues, is that if we lose an implant or two, we still should be able to proceed with treatment without delay. Here's his before and after lips retracted. Hard to believe it's even the same patient. Here's his before and after smile. Talk about a happy customer. And again, same as the other two patients, 5 months, 5 appointments, 3 trips to Dallas. Case 4. This patient presented with several good teeth. Well, I should say more than several. He had 8 good teeth. And like I described earlier in the video, when we do take out good teeth is a decision made by the patient and me at the treatment plan. He knew these 7 front teeth would need new crowns. So that alone was going to be over $10,000. So he elected to put that money into a fixed temporary. His back teeth were so good, and I decided, I should say, I encouraged him or recommended that we keep those 2 back teeth, which is a pretty lengthy discussion about proprioception. If you can leave a tooth or 2 in one arch where you can feel how hard you're biting, that does help some patients with forceful bites know how hard they're chewing, because implants don't really give you the same feedback as natural teeth. So he needed bone in the back of his mouth. So his was a prolonged treatment because we bone grafted his sinuses first. Here he is before any treatment here in Dallas. Here he is after the first sinus grafts, and I did place 2 implants. We left teeth behind. I call this my transitional implant treatment, and I've described it in several other videos, but basically what it is, we try to give patients beautiful temporaries to leave here with, whether it's on teeth or implants. In this gentleman's case, the bone grafts needed to heal for 8 months, so we left 4 teeth and 1 implant to support the temporary while those bone grafts were healing. I placed 2 front implants to be prepared for the next surgery. His first fixed temporary that went on 4 teeth and 1 implant looks like this. Same design though. Here he is leaving after I'm sorry, this is after he returns 8 months after that original surgery. Then we take out the remaining front teeth, place more implants, leave the 2 molars, because if you notice that the back molars only barely touch the lower teeth as it is, but it's enough pressure that he can feel how hard he's biting. So that's his post-surgical radiograph, and that's the way his temporary looks on the implants and the implants in front and the 2 teeth in back. You'll notice the soft tissues haven't changed at all. Picture of the soft tissue development. His final restorations. And again, practically no change to the tissues at all. Some of that has to do with what we call biotype, the thickness of the bone and the gum tissues that you were born with. The better the biotype, the more results like this we get. The more delicate the biotype, we still get results like this, but it's a little trickier and requires a little bit more finesse. His final panoramic x-ray. Before and after lips retracted. And we don't have a before smile, unfortunately, but we do have the after smile. Because it required bone grafting and 8 months of healing, this total treatment time was 15 months, 7 appointments, 5 trips to Dallas. Moving on to case 5. Here's a former hygienist from Pennsylvania, actually, my home state. Her teeth look great, so you might wonder why she's here talking to me about upper full arch implant treatment. Turns out that she genetically has very bad periodontal disease, and she's lost quite a bit of bone around some of the front teeth and a couple of the premolars. And so at 70 years old, she's ready to do something now rather than wait. But she was afraid of waiting into her 80s when she may not be able to have this treatment rendered, may not be able to afford it. Who knows all the stimulating factors, but she's here, flew to Dallas to get a consultation with me. I think we did a Zoom consultation the first time, and we got some preliminary models, so we were ready for her surgery when she came to Dallas the first time. So, like so many of our other patients, we got all the teeth out and all the implants in, which was 6 for her. That's all her bone would accommodate, and the fixed temporary on the first surgery. I placed additional implants that we did not load that day, but I think she has 10 implants, and some of these did not work out, but I call them bonus implants. If they work out, great, and if they don't, it just means we have to maybe leave off the second molar in the final restoration. So she leaves here with her fixed temporary, and you'll notice that the temporary fits up against the gums very intimately, and that's the goal of these temporaries. I've worked with this protocol and this process for 30 years. Started on teeth, carried it over to implants, And this is the result of 30 years of kind of trial and error that got us to this point. So that's the day of surgery. She goes home and heals, comes back, and words almost escape me. This is so beautiful. The tissues have developed beautifully. The bone was nice and thick to start with, but she had all that bone loss around several of her teeth, and we still had a result like this. Here are her final restorations. We did bleach her lower teeth, but if you look at these contours, it doesn't get much better than this. In fact, I might say it doesn't get better than that. There's her final pano. You can see we lost the one very back right implant. It was a bonus implant anyway, all the way back to her wisdom tooth, so not needed. We cantilevered a first molar, so she has 13 of her teeth, more on the upper than she even has on the lower. Before and after lips retracted. I'm just now noticing for the first time that we were able, by designing the shape of her new teeth a little bit more squarely, she lost the black triangle between her two front teeth, which means she won't get food impaction there like she did when she had her natural teeth. Before and after smile. And because we did all this in one surgery, we actually started and finished in 4.5 months, 5 appointments, and 3 trips to Dallas. Again, just to reiterate, when we start the prosthetic phase of treatment, which is the impressions, the records, and the try-in, we do all 3 of those appointments during one visit to Dallas. So if that's confusing to you, that's why there's 5 appointments but only 3 trips to Dallas. Case number 6. Another female patient who had put a lot of time and money into her teeth. She was tired of continuing the downward spiral with root canals and crowns, then broken teeth. She's a very significant grinder, and she did break her temporary a couple of different times, and I'll mention that while we're at it. If you break temporaries, if you're not exceedingly careful with your temporaries, that does require extra trips to Dallas. So we try to implore people to chew only the softest foods, and the way we tell people is if you can't cut it with a cheap plastic fork, you shouldn't be chewing on it. And that keeps people safe. And then we also make a nightly wear mouth guard that we really strongly urge people to use, and many don't. So if you have to come back to Dallas, the treatment does get more expensive. So that is on the patient to be as careful as possible. So again, I'm looking at bone volume to evaluate how much bone, if any, has been lost. And in her case, she has no missing bone. Her lower arch we're going to do next year, sometime in 2025, but her bone volume is fantastic, which means we should get a nearly perfect result for her. So here's the panoramic x-ray of her first surgery. Her bone density was so high that I really struggled to remove these teeth. So we left 7 teeth behind. More is better for people with a really strong bite or intense grinders. The more teeth you have, the stronger the temporary. Because I hope to place an implant in the molar site in the future, she's going to wear her temporary that you'll see here in just a minute. She'll wear that for 6 months rather than the standard 3 months. Here is her temporary that we made her on her first surgery. This is all on teeth, not engaging any of the implants. And again, she'll wear this for 6 months while the back molar sites heal, so that I can hopefully place an implant in those sites in 6 months. So she returns in 6 months, and we placed more implants. But on this particular day, her left lateral incisor, her number 10 implant, failed. So because we didn't remove any bone, we were able to just move over to site number 9, the left central incisor, and place an implant there and make a new temporary for her that day. And I mentioned biotype in the last patient. Her biotype is incredible, and you'll be surprised how well her bone recovered. Her bone and gum tissues recovered even after a failed implant. So this is that particular day. Because the number 10 implant failed, we placed an implant at number 9, but the number 9 implant was not strong enough to accept the temporary that day. So the temporary now has a long span across the front, and that is not a good thing, mainly because she's a grinder clencher. But also, if you look at her lower teeth, she doesn't have premolars on the left side, and all of those forces of biting are right there where the temporary bridge is unsupported. She did break this at least once while she was healing. This is the temporary that she left here with after her second surgery. And you can see the cylinders are a long way apart between the right lateral incisor and the left first premolar. So this area is going to be weak. Her teeth are fairly short. That's going to be one problem. And her bite force is strong, and that adds to that problem. In spite of the number 10 implant failure and the placement of the number 9 implant, look at how nice the tissues have recovered. It's pretty remarkable what can be done as long as you're not taking away a lot of bone at any of these surgeries. Here is her final restoration. Here is her final panoramic x-ray. Sorry about the earrings. Every once in a while my assistants forget to have patients take out their earrings and they superimpose on the teeth. Those are just hoop earrings, nothing pathological. Here are the before and after lips retracted. Before and after smile. I would add one more thing. You'll notice some of these smiling pictures are not very natural. And I can tell you that after 34 years of doing this and treating people with really bad teeth, many of you with bad teeth know this, that you're protecting your smile and guarding your smile all the time. And you never really even know what a normal, natural smile is. It may take months or sometimes even a year for people to finally give up those old habits and start smiling naturally again. So some of these don't look all that great, but even here within this time frame for this patient, her smile is much better after treatment. And because we had that failed implant, her treatment time was 10 months. She had 6 appointments and did come to Dallas 4 times. It might have even been 5 for one of the repairs of the broken temporary. Case 7. Probably 15% of the time we have patients who come in that don't have any teeth at all. And the bone loss, the natural bone loss that happens when the teeth have come out varies significantly. This gentleman actually did not wear any dentures for many, many years and finally decided that it was time to fix his teeth. Or get some teeth, I guess I should say. But the good news here is he's got a very broad alveolar process, meaning the bone is very broad and thick, and the soft tissues are outstanding. His lower bone volume is less, but the soft tissue health is quite good. And here's his panoramic x-ray. You can see that he's got pretty good bone in the upper front, excellent bone in the lower front, and we do take CT scans on all of our implant patients, but there are some techniques for adding bone in the upper back of the mouth that don't require much extra surgery at all, and we did that for this gentleman. I call those direct sinus lifts. You put the bone through the site where the implant's going to go. So we were able to get 8 upper and 6 lower implants in. In the lower back of the mouth, the bone was just too thin to place implants. But the 2 upper back implants, I did add bone ahead of the implant on both of those sites. So he was wearing nothing at the time he got the implants. So we elected for him, or he elected to go without anything while the implants were healing. He heals for 3 months. Then he comes back and we make him fixed temporaries. And in a case like this, we took his old denture and modified it, but the tissue portion of these temporaries I didn't show you because we didn't photograph them. 3 million photographs in 36 years, and we occasionally miss a few here and there. So these served as his temporary, but the way I did my incisions on the day that we gave him these teeth facilitated more good tissue building that you'll see at the very end. I can't give away all my secrets. But look at the tissue development that we had from a person with no teeth at all. Now we've got probably 30 to 40% of a papilla between the teeth. And that comes back to the second surgery, how I do the second surgery. So look at that. I mean, that is just a beautiful thing to behold. Taking a person from no teeth to implants and being able to have that kind of connective tissue response. So here are his final restorations, and he's one of our patients that wanted to go as white as possible, so that's why you may need sunglasses to look at this picture. But the main thing I want you to see here is that his upper arch, there's no pink. We've got some semblance of a papilla between the teeth. And on the lower arch, he had lost enough bone that he had to have some pink zirconia down there. But all in all, an amazing case. His final panoramic x-ray. Before and after lips retracted. And his final smile picture. His case did take 6 months, 5 appointments. He lives in Dallas, so he had 4 trips to our office, 5 appointments total, where we piggybacked 2 of them. Case 8. This is another just amazing transformation that I don't even realize until I start going back and putting these cases together. This patient has numerous problems, bone loss, periodontitis, decay, calculus, missing teeth, and not great bone, which is another, just I'm flabbergasted when I see the final results on these, because you would never know it was the same patient, and I'll show you that here in just a few slides. So this is his preoperative panoramic image, and you can see almost 100% bone loss on the left lateral incisor, tooth number 10, and generalized bone loss ranging from 30 to maybe 80% on all his other teeth. But in general, his bone volume is good. I look past the bone loss around the teeth, and I look at how much bone remains, and this is where this type of philosophy or protocol that I've developed over the last 30 years, it's what I would want in my own mouth. Unlike the doctors who do all on 4, who would never have that treatment in their own mouth. First surgery, we took all the teeth out, put all the implants in, and he gets this beautiful fixed temporary with all the proper contours. Lower the same. He had lost more bone in the lower, and occasionally we do have to take some bone away in the lower, but here's his lower temporary. Here's his panoramic image on the day of his first surgery, and you can see on the upper we did leave 2 implants on the right side that were not stable enough to have a temporary, but with, what is that, 16 implants, we're able to give him fixed temporaries on the best 13 implants, which is more than enough. The day of surgery, his temporaries and the tissues on that first day of surgery. And here he is 3 months later. The lips retracted soft tissue architecture, and again, just mesmerizing. I can't get over how amazing some of these cases, most of these cases, are. And here you can see that left front and left second tooth, the left central incisor and the left lateral incisor, are longer. But as you recall, he had 100% bone loss around that left lateral incisor, but we were able to still finish his case without any pink zirconia on the upper. Here's his final panoramic x-ray. Before and after lips retracted. Before and after smile. This treatment took us 8 months, 5 appointments, 4 trips to Dallas. Case 9. This gentleman had been in my care for 15 years, believe it or not, and it's an interesting story. But I want you to notice how war-torn and ravaged his dentition is. Another intense grinder, high-stress job. He had already had some implants placed, but when he first came in, he had a really badly infected tooth. As you can see here, he had a fractured and infected right canine. So the first thing we did for him was take that tooth out, and I made him a large temporary. So here's his first temporary that I gave him, gosh, must have been 2010 or so. He wore this for way too many years, 10 or 12 years. We might have remade it once. Too busy to come in for treatment. So when he finally does come back for treatment, he needs some bone on the in the right sinus before I can do any implants there. But in cases where the patients have 4 or 5 or 6 millimeters of bone, we can sometimes place the implant and do the bone graft at the same time, which is what we did for him. So these are new temporaries that he began wearing after his first surgery. I'm sorry, after his second surgery, which was the bone grafting surgery. I want to just point out these are his third set of temporaries, and now all his implants are in there, and we're using the implants to support the temporary, same as I've shown you before with all the proper contours. You can see the bone graft we did in his right sinus and the additional 6 implants on the upper with the 2 that he already had. But remember the war-torn, ravaged dentition that he had when we started? I would consider this biotype to actually be excellent now, as if nothing happened in the past, which I wouldn't know unless I took all these pictures. Here's his final restoration. He has a full upper zirconia bridge. On the lower, he's got zirconia implant crowns and natural tooth crowns. Here's his final panoramic x-ray. Before and after smile. And like I said, I'll just go back to his case, 15 years in the making. Most of that happened in about 9 months once we finally did get started in 2023. Case 10, our final case for today. This gentleman comes in with this is called a class 2 deep bite, meaning you cannot see his lower teeth at all when his mouth is closed. But what I am looking at that I like a lot is that his bone volume seems to be quite good. His connective tissue or his gum tissue or gingiva, it's called all 3 of those, is outstanding. He's got more connective tissue volume than most people by a lot. And again, I'm looking at bone volume, and surprisingly, even where he's missing teeth, his bone volume is quite good. So that first surgery, you can see I've left some roots behind, but I placed 8 implants, and he leaves here with this fixed temporary on those 8 implants. This is the day of surgery. And here he is 24 hours later. Every once in a while we have patients who come in from out of town that like to stop by the office the next day just to get a checkup before they fly back out of town. But I'm always amazed when you do minimal bone removal surgery and you're careful with your implant placement and careful not to disturb the tissues, well, just say as little as possible. This is what it looks like in 24 hours. We did his lower 2 or 3 months later. Same technique. He leaves here with a temporary that day. So his upper's been in there for 3 months now. His lower has just gone in that same day. And then this is what he looks like 3 months later. Some of this staining, I believe this patient is a smoker. Of course, we discourage that. Smoking does decrease implant success rates. But this is some of the staining here, but the tissues look amazing. This is what we try to do all the time with our techniques. Just to show you what the tissues look like before the permanent restoration goes in. And another thing I'll mention here is that I've gotten away from doing individual bridges. I now do one-piece bridges. That 3-on-6 concept that you may have researched or heard about, I did a lot of that in the past, but I found that if an implant fails, usually we can just take the implant out and put the whole bridge back in without any interruption in care. With the 3-on-6, if you lose one implant, you have to have more surgery. And I used to say that the 3-on-6 was easier to clean, but that's only easier to clean in 2 spaces. So this technique for me has evolved over the years to being a one-piece upper or lower, whichever arch we're working on, not individual pieces. We also get a biomechanical advantage of cross-arch stabilization, meaning all the implants help support each other when you're putting a one-piece bridge in. But anyway, notice the papilla in this gentleman's case. I'd say we were probably at 70 to 80, maybe even higher than that % of maintaining that little triangular piece of tissue between the teeth called the papilla. And the lower soft tissue is also outstanding. Lots of volume, and the only red spots are where the acrylic resin was touching his gum tissues. Here's his final restoration, and I would say this is as good as implant dentistry gets. We have many cases like this, but his case with his biotype was just remarkable. Final distorted panoramic image, and yes, my assistants are getting in trouble as we speak over the panoramic image quality. Before and after smiles. This gentleman had been guarding his smile for so long that he still couldn't quite muster a full smile when we asked him to, but the improvement is noted. So because we did upper arch first and lower arch second, this took us 11 months, 8 appointments, and 6 visits to Dallas. I'll comment on that as well. One of the things we do is to allow patients a longer time to pay. I said this in the front end of the video. To get this much better treatment than All-on-4, sometimes people can only do it in longer treatment times, or they start with one arch and come back to do the other arch. So this case could have been completed in 5 months, but the patient needed 11 months financially, and sometimes, like I said earlier, we go even 2 to 3 years, as long as you're not breaking the temporaries and you can pay for it over a longer period of time. We are happy to accommodate that. We want you to get an outcome like these 10 cases, not like you saw on the all-on-4 slides I showed you earlier. And finally, I'll have the other 10 or 15 cases to show you in the next few weeks, maybe a month or so. I'll look forward to that. And as always, thank you so much for your time. Thank you for subscribing to this channel. We really appreciate it. So I hope you enjoyed those 10 cases. They are even better than I remember. When I go through these pictures and realize the transformations that we were able to give patients, it's mind-boggling for me too. And this part of it's really fun for me to. It's almost like nostalgia or reminiscing. But I've got 15 more cases to show, and those will be forthcoming in the next few weeks, maybe a month or so. So stay tuned for that, and please make some comments below. Thank you.